Well, good evening everybody. Isn't this just the best fun? Fancy doing this from the comfort of your own home. I would never have believed it. Anyway, my name is Barbara Lamb. I am going to be telling you a little bit about radiographic techniques tonight. I am a whole body radiographer. I've specialised in head and neck for, it seems like hundreds and hundreds of years, but in fact it's only a bit in excess of 35 years. I've worked in hospitals, communities, I've been involved in research, I have worked single-handed, I've done a lot of undergraduate training, and then postgraduate training became more and more till I gave up the day job and decided just to do the bit that I enjoy best, which is teaching. So I now give courses all over Britain. I teach Section 63s in Scotland for CPD. I work for corporates. I do private in-practice courses. All in all, I just have a wonderful time. I would like to talk to you about radiographic techniques tonight very much from a practical aspect. Everything I talk about relates to when you press the button. And I'm sorry for those of you who are coming from all over the world tonight who will be having to spend a little time getting used to my Glaswegian accent, because although I now live in Wensleydale in the beautiful Yorkshire Dales, I still live part of my time in Glasgow and I'm a Glaswegian through and through, so my Scottish accent might take a little bit of getting used to. So let's have a look at radiographic techniques and see what I think are the important parts about it from your point of view. We can't talk about technique until we actually look at how we make the X-ray. So let's first of all look at our X-ray tube. Now our X-ray tube has got oil, and surrounding the oil we have a lead housing, and that's what you hold on to when you position your tube head. But we have inside there, we have Pyrex, thick glass tube. Pyrex is very strong. In fact, when I was little, we used to eat our dinner off Pyrex plates, and even when you bounced them off the kitchen floor because you really wanted a new plate, they never broke. So they're very thick. Inside here we have a vacuum, and we make our X-rays. With dental X-rays and medical X-rays, they're man-made. So this is how we do it, and I want to relate this directly to what happens when we press the button. On the left-hand side here, we have a cathode. It's negatively charged, and we have a little tiny filament here, which is made of tungsten. Tungsten is our metal of choice when we make X-rays. They give us the characteristics that we're looking for to give us good X-rays, that give us good images and don't give the patient huge doses. So we have our filament here on the left, which heats up. It's a bit like a filament inside an electric light bulb. It's going to heat up and heat up and heat up till it almost starts to boil. And then around here we have a cloud. The cloud of electrons that is around the filament is actually the milliamperage, is actually the blackening on our X-ray film. Now our machines are normally set at a specific milliamperage, maybe 7.5 or 8, but if we're working with digital, it can be half that. But what actually happens here is we can change the amount of electrons that sit around this cloud by having our finger down on the exposure button longer. So if we have a longer exposure, we have more electrons around the cloud. Now I always think of them as little Ribena men. You know the lovely blackcurrant drink that dentists hate because it rots teeth. If you have a few Ribena men in a glass and lots of water, we don't have a very intense colour. But if we have lots of Ribena men inside that glass when we're making our blackcurrant drink, we have a much more intense colour. So the more Ribena bombarding electrons that we make these little Ribena men, the more intense, the more black our film is going to be. So they congregate around the filament, and then we use a step-up transformer and we throw them across that X-ray tube at the greatest of speed. They go across very quickly, and the speed that they go across, the potential difference between the cathode and the anode, is our kilovoltage, is our penetration of our beam. is the ability of our beam to get through the tissues that we are X-raying. So it's very exact. We would want to work with a high kilovoltage for maybe periapical pathology and a lesser kilovoltage if we were looking for caries. In a perfect world, that works very well. If we can't change our kilovoltage, what we can possibly change is the amount of X-ray of the little Ribena men that we have here, so we can change our intensity. But the bombarding electrons coming across here give us what is called the quality of our beam. They hit this target, which is called an anode. It's also made of tungsten, and they go at such a speed that when they hit it, they give out all their energy and they just relax. They give out all their energy, and the energy turns into predominantly heat. 99% of heat and only 1% of X-rays. But the X-rays we get here are still not the ones we use. We filter off the ones we don't want, and we only end up with the very best ones that are allowed to come out through this X-ray window. We filter off here as well, so as we filter off the ones that are just going to give us a dose but not a particularly good film. So let's move on. Have a little look. Negative cathode heats up, emits electrons, bombards the targets. They come to rest. The target is surrounded by copper, and we all know that copper pots are awful good at heat dissipation, so we use copper there to dissipate the heat. We have a high voltage between the cathode and the anode. That's our kilovoltage. We can see it on our films. Good penetration at 70, not so good penetration at 65. Not so good penetration at 65 gives us more absorption in the tissues, more shades of grey, lovely films. When I started out as a very young radiographer 450 years ago, we worked with 50 kVs and slow film. So the patient got a higher dose, but our films were absolutely fantastic. So our current flows between the cathode and the anode, that's our MA. We can change that to MAS, and we can change the amount of current by giving it a bit longer on the exposure button, gives us a blacker film. The lead casing absorbs the unwanted X-rays, and the oil casing removes the heat. Electrons are brought to rest, we get lots of heat in the X-rays, mostly heat. The heat's dissipated and the X-rays are emitted through the window. Along come the Ribena bombarders, the little super bombarding electrons. They hit the target, and at that stage they are sent down through the window. And what is on the end of the X-ray window? A spacer cone. And the spacer cone is the cone that you hold on to when you are lining up, when you're taking X-rays. So, what I would want you to have a look at, though, is how we use the relationship of blurring on the film in relation to the focal spot that we have inside our X-ray tube. So, when we actually work with the broad one coming across here with the bombarders, they come across at such a speed that when they hit here, if they were narrower, they'd melt this. So we can't have it too narrow. We'd like it narrow, but we can't have it too narrow, because if they hit this target, they would surely melt it if it was a very, very fine focal spot. But very cleverly, they've worked out, if we put the target on a bevel, then the beam that comes down through here has an apparent focal spot. What would happen with the large focal spot, which we started off with, is the beam comes from there, it gets to the tooth, it crosses over on itself, and we get blurring here and blurring here. But using the fine apparent focal point, we have a much, much smaller focal point. The beam comes from there, gets down to the tooth, meets perfectly, and we don't have blurring on the edge of our films. It's very clever, isn't it? Now, here we have, marked on the outside of our lead housing on our X-ray tube, a red mark. It can be a black mark, it can be a convex or concave dot, but this is our target, where the bombarders hit. It's called the anode, the target, the focal spot, the focal point. Lots of words, all meaning where we make our X-rays from. And from there to the end of our spacer cone is a very specific distance. When we work with paralleling technique, the distance is 20 centimetres. It didn't used to be. Back in the day when I started out, we were working with 10 centimetres, but now we work with 20 for lots of very good reasons, which I'm about to explain. When we worked with the shorter spacer cones, we ended up with a beam that came out and was fastly diverging. Now, I must have hit that little circle earlier because it was in the right place earlier on. So apologies, let's just imagine that's further down. The beam comes out of the spacer cone, it's fastly diverging, giving us extensive magnification of the image. It's a short focal skin distance. Now, that was all right when we worked with bisecting angle, i.e. when a patient held the film in the mouth with their finger. But that technique isn't really good nowadays because we cannot monitor anything. And I've been using paralleling technique for at least 35 years. I have been using rectangular collimation for probably about 32 to 33 years. I remember well because I was not in a good mood when it started, and I was coning off and finding that I was missing bits on my films and I wasn't in a good mood, and then I found out why I wasn't in a good mood. Because I was pregnant and the baby is 32. So I've been collimating for that length of time. So paralleling technique is the way to go. It's the only way to go. We can use bisecting as the backup technique for difficult patients, but sometimes the technique of choice may be for oral medicine. If we're wanting to work with occlusals, we want to see larger areas, we're looking for infection, tumour, cysts, that's when we use bisecting angle. And to be honest, I wouldn't even use the finger hold, I would use occlusal films. That's, I think, the best way to go about it. So the long focal skin distance has given us 20 centimetres. Now by the time the beam comes out of the spacer cone, it has paralleled itself by physics. Not by the spacer cone, but by physics. So we have now a parallel beam. We have now got minimal magnification, and that allows us to take films inside the mouth without being so worried about having the tooth and film all snuggled up close together, because our mouths are not the right shape to do that. The intensity of the beam we can vary by the quantity and the number of photons, by the finger down longer, the longer exposure. The quality is a measure of the penetrating power, our kilovoltage, how fast our little bombarders come across that tube. Factors that can affect these: the distance from the target, because remember we use a long focal film distance to allow us to have a nice parallel beam, but when we have a distance from our target material inside the mouth, that's when we use our 20, but our distance from the target inside the X-ray tube is also important. The time and the length of the exposure, not if exposure, of exposure, and the filtration that we use to take off the harmful low energy soft X-rays. The X-rays travel in straight lines in free space, but they also obey the inverse square law. That means if I take an X-ray at 20 centimetres, which is perfect focal skin distance from the anode to the skin, if I change that to 40, I wouldn't double my dose to the patient, I would have to quadruple it, because the beam dies off so fast. Double the distance from the source will reduce the intensity to a quarter, and this is a big form of radiation protection and dose limitation to the patient and also to the staff. So double the distance from our source, and we can put 4 of these in there. It's like light coming from a light bulb. Double the distance, quarter the dose to the patient. When taking paralleling periapicals, we want an ideal geometric relationship. Tooth and film as close as possible, film parallel to the long axis of the tooth, and the central ray directed at 90 degrees to the film and the tooth. We can use 2 different techniques. Paralleling is what we're talking about this evening. Bisecting is the backup technique, sometimes the technique of choice, but for endo, for caries, for pathology that you want to monitor, for these reasons, for perio, particularly with our bone levels, we want to have something that we can monitor. And we can monitor with paralleling technique. We cannot monitor with bisecting angle technique. It's too difficult. We have an angle on the head and an angle on the tube. The film sizes that we use intraorally, well, the occlusal one here we use for bisecting angle, and that would be my choice if I was going to take a film with bisecting. I want a lot of information, please, if we're going to use bisecting angle technique. But for a paralleling technique, we'll be using size 2 and size nothing. And these are the two films that we will use when we're taking intraoral films. Anterior films are done on a size nothing, and they are going to be vertical, always. And posteriors are going to be done in a size 2. And normally, apart from with vertical bite wings, they will be placed horizontally. We don't need to have any more than that. This film here shows you how. You might think, well, let's use the bigger film because we get more information. But what happens when we use a bigger film on anteriors? This is a size 2 film placed in vertically. What happens is we cannot see clearly what's going on here. We're starting to get trabecular blurring here. But the teeth in question, which are the central and the lateral, are not positioned correctly to allow the beam to go straight through here. We're getting this space and this space, but we're not getting here. What we're also getting, because the film is so long, the film has had to be tipped to allow it into the mouth, which has brought our beam down at the wrong angle, and you can see by the length of the 3 that we're now talking quite a substantially foreshortened image, which isn't true to life, and hence this is not the ideal film size for our anteriors. In our anteriors we will use these bite blocks. They're the blue ones. Now, I've been using RINs my entire life as a radiographer, bringing in other ones to try them out, and always going back to RIN instruments. There is nothing on the market that can touch them. They're fantastic holders. I love them, and I recommend them to everybody. They last you a lifetime. When my daughter was working in Australia in the outback, Mum, we've no RINs. We sent them out to her, and she's carried them round with her. Really important to have good instruments when you're taking x-rays. It's the eye into your practice. You want everyone to see just how good you are. If you take good x-rays, you take just about good everything else. So here is our bite block. This one's a cut down, and we've got the cut down there and cut down there, and this is just where we trim off the top, and we can use this to do paralleling technique on little chicks, the little ones that can't cope with the full size bite block, but for some reason we want to take a film that we can monitor and we can look at as we go down the line. Then this is what we would tend to do for the tinies. This is a spacer cone which is already rectangular. We can get rectangular collimators that go onto the end of the round cones, and that's what I've been using for over 32 years, is collimating down. It cuts our exposure to our patient by at least 30%. Now this is a collimated spacer cone, which therefore means it cuts down on every exposure from the circular beam. The circular beam is about 60 millimeters across, or 6 centimeters, and the spacer cones that are collimated are usually coming in at 5x4, so there's a substantial drop in radiation to the patient. And in fact, you can see the extra bits around the edge. We don't really need them. We've got notches on our RINs to allow us to be absolutely perfect when it comes to lining up. Posteriors, we've got yellow blocks, rings and rods. Sometimes you get old-fashioned ones which have got longer rods. They just tie up with the older spacer cones which were longer, and they're quite okay to use unless your spacer cone on your new machine's only little and you keep hitting it against the rod against the tube head, in which case you would want to cut them off to the length of the new ones. Some time ago we used to get this depth of block, and nowadays we tend to get this depth of block. And what we tend to do a lot of the time is cut them off a bit, get them to this size, so that we can get in to the back of the mouth. They're great holders, they last, but sometimes the bite block can be quite difficult for us to get in to the back of the 6s onto the 7s and the 8s. Yes, I have a question. Can we use a size nothing film for a canine? Most definitely. We'll be getting onto that shortly. With these posteriors, we're going to be cutting down as well, and we can use them for the little ones, and we can use the size nothing horizontally to take posteriors on deciduous teeth. It's just what we automatically do as radiographers. We start to use all of these ways of cutting down our blocks so that we get everything we possibly can. We have lots of bite wing holders. We have vertical ones here, and we've got vertical ones here and here. Most people, to be honest, wouldn't tend to use this little baby vertical, but they would use this for perio patients, and these are predominantly going to be used for caries. We'll go into them in more detail. With paralleling technique, tooth and axis of film packet are parallel. Our beam is going to be at 90 degrees to both. We must have film holders, and good film holders. We're going to have an increased film object distance to allow us to become parallel. We're going to use a parallel beam, so it's not a worry. We can have increased film tooth distance. The increased source object distance is necessary to minimize our magnification, and the position of the film is going to control vertical and horizontal angulations. We have to have sufficient image receptor to record our apical tissues, and our parallel beam meets both the tooth and film at right angles, and the tooth and film in a perfect world are in contact, but they're not normally. Ideal geometric relationship between the tooth and the receptor is the parallel beam coming through at right angles to the tooth with no magnification, a perfect image onto the film. But to be true, for tooth and film to be parallel, they have to be some distance apart, and we actually use the height of the palatal vault to allow us to get parallel to the tooth in question. If the object position is not ideal, the tooth position is not ideal, we are going to have foreshortening. If the image receptor position is not ideal, we can have image elongation. And if the X-ray beam position is not ideal, yet again, we do not have a true image. Our film holder components, we have mechanisms for holding film packets parallel to the teeth, so we have there to support the film packet. We have a bite block, we have an we have a rod and a ring to allow us to aim directly in the correct position, using our collimator matching in to the notches. We have to be geometrically accurate. These are easy to use. They're reproducible films with accurate representations of periodontal and periapical tissues. Upper anterior paralleling technique. We want to have the head as straight as possible. It's very difficult to have the head with the patient lying, to actually envisage where the teeth are with the patient lying back in the chair. So you tend to see in X-ray departments that specialise in dental work, the patient is sitting upright so that we can use the occlusal planes. The upper occlusal plane is going to be parallel to the floor. As you look at the head there, we can envisage where the teeth are lying, so we're going to be able to see parallel as we position. If the head is back, we're not going to be able to do that. So we'll use ala tragus for upper, and we'll use corner of the mouth tragus for lower. So it's straight head for upper and chin up for lower. For the upper teeth though, what we want to do is pop in a bit of cotton wool, just a tip of it, because I need to make sure that the film is lying truly parallel and in exact line with the long axis of the root. Without the cotton wool, the lower occlusion is going to determine that, and I don't want that. I want to determine it. So I stand on the side that I'm x-raying, be it a right central, I stand on the right side, be it a left central, I stand on the left, so that I can be absolutely clear where my film is going to be going. Cotton wool goes in and the film is flattened with the ring to the back of the rod. In goes the film flat into the mouth, and it's like feeding a great big baby. You go right in to the palatal vault and bring it back up to vertical, bringing it slightly towards you so that the film is supported on the back plate, doesn't tip off the back plate, and then we sit it down onto the cotton wool. At that point, the spacer, the circle that is going to allow us to line up is up at this end of the rod, which is going to give us far too far a distance of focal skin distance. We're going to be well beyond our 20 centimetres. So what we have to do is bring the ring into skin, allowing us now to be in a position to line up with our collimator after I have checked that everything is absolutely perfect. I can't check with two eyes. I can see way too much with two eyes. So I am right-handed but left-eyed. So my left eye is open, my right eye is closed. I'm looking through the centre of the ring, exactly through the centre, just like my X-ray beam is going to go. And I'm going to see through, and I can see where that beam is going because I pretend my eye is the X-ray beam. I can see exactly what I'm going to get. I can change the cotton wool slightly, or change the film position slightly to make sure that I get exactly what we're looking for. We can see through the ring, we can see where the beam's going, we can see what spaces it's going to throw open. An eye will see through something just like an X-ray beam will. And if we can see through it with our eye and that's where the beam's going, the beam will see through it as well. On comes the spacer cone down onto the ring, giving us our focal skin distance of 20 centimetres. Nice parallel beam, and we use almost the whole of the block to allow us to get into the vault. Nice, correct length of teeth, something that can be monitored down the line. If we have an area that is missing, if the tooth is missing, let's give them a pretend tooth so that we can line up correctly. The pretend tooth would be a piece of cotton wool above the block if we're missing teeth. So we can then line up along the arch line, making sure that we don't get what I call the Popeye effect, when a patient is biting down onto an edentulous ridge and the film is pushed way up into the air out of parallel. What has happened here though is that this area hasn't been fully supported with cotton wool, and if it had been, we would have been more central and more upright, and we could have had the supporting under the block cotton wool sitting around here. If we'd looked through the ring, we could have told when we looked at this that the film was slightly off and pull the whole thing up into central and parallel to the film. Very easily done when you use your eye as the X-ray beam. If you have the head back in the chair, we can see the left hand side looks okay, but in fact the right hand side looks pretty similar. This one on the right is wrong. We're in a strong foreshortening position, but our eye is confused because our head is in the wrong position. So let's use the head positions to give us the correct eye view, and that is aerotragus parallel to the floor and corner of the mouth, tragus for our lowers, chin up. So the only time we put cotton wool on the top is when we're maybe filling an edentulous area, or the patient who possibly has had surgery or who has maybe cleft palates, maybe has had radiotherapy, they've got very, very low palates, and this is a way of lengthening the tooth slightly to allow us into the palatal vault and to allow us to be parallel. If we were going to do this, we would get the patient to bite a bit harder on this till it's about half the size, and that would give us enough without us losing the tips of the roots. This one is for the little ones. You can literally half your film. The front bit gives us the info, the back bit is lost. So we know the back bit's no good. But we can't put that into an automatic processor. You'd need to put processing chemistry into little denture bowls and process it in your dart box or your dark room, so that we didn't upset the processor. But it gives us very nice information, which again can be monitored and reproduced down the line. This film is done for the upper three. The 3 is always done by itself. Don't try and tie it up with anything else. Have the 3 by itself and the 2-1 get done together. But the 3 is done by itself. Because what happens is, even when we try really hard to get through the spaces, we end up with a bit of a problem with overlapping on the distal of the 3 onto the 4, as you can see here. And it's quite normal to see that happening on a picture of a canine. So we either have to go back, if we're looking for distal caries or we're looking for bone levels, we're going to have to go back in and do another film, which is going to try and separate them apart. the way to do that is to do a distal-mesial angulation to separate the canine and the premolar, usually by about 7 degrees. We come distal-mesially, throwing that space apart, and what we're actually doing is that we're coming into the area that we would normally be coming in with the beam on a premolar area, and it throws the bone levels apart and gives us a better view of what's going on. Lower anterior positioning, we're still going to be quite far away from the tooth in question, and we're going to be using cotton wool again. The chin is going to be up, and you're going to check the buccolingual expansion. Open the mouth and have a feel on the area that you're going into. When you're there feeling the buccolingual expansion, I want you to run your finger down into the floor of the mouth. At that point, you're finding the softest part of the floor of the mouth, and you're feeling the thickness of the buccolingual expansion. Put the film onto the incisal edge of the tooth in question and hold it right down there. You've told the patient, see where I'm touching with my finger, that's where you'll feel the film. In goes the film onto the incisal edge. Be firm and be confident. And when you hear the tooth and the plastic of the block hitting together, you hold it there firmly. Pop in your cotton wool and ask the patient to bite and hold. The cotton wool on all anteriors is put in like a cigarette. On the lower ones it's much easier for the patient to bite, and on the upper ones we need it to get our angulations correct. As they bite together, the floor of the mouth relaxes even more. So in we go. Flat film, bringing up into position, down right onto the incisal aspect of the tooth. Pop in the cotton wool and bite. Patients always smile when they get x-rays done, because then they will not let their teeth come apart. Big smiles, check through the ring, check that the beam is going exactly where we want it. And to be honest, with lowers, it's very, very easy, because you actually are positioning your film when you go into the floor of the mouth exactly where you want it to be. Line up with your spacer cone in position. If the head was in the wrong position, you would be finding it very difficult to see through the ring and very difficult to line up with your spacer cone. We can do profile views with our anteriors as well for things like dilacerated roots. With adults, it goes under the lip. With children, we use the bigger film and it goes outside the lip. The teeth bite onto the block. This one would be for the left central, and you get the tooth as far forward on the block as you possibly can, so that we don't miss the roots sitting up just in about this area here. If the teeth are too far back that way, we're going to miss out on the roots. Upper posterior positioning, we'll start everything at the molar area. We use the yellow bite blocks, upper right and lower left, and upper left and lower right. These cover premolar and molar areas, and you want to always start off at the molar area. Upper posteriors, we need to use the palatal midline at the highest point, and on the lowers, we're going to go into the softest part of the floor of the mouth. Again, you're going to be check where you're going as we go. With the uppers, let's get our head right again. So we're back to upper occlusal plane parallel to the floor, approximately ala of the nose to the tragus of the ear, parallel to the floor. A nice straight head. Cotton wool lies along the line of the arch, coming out, and I use my weak hand and I don't let go of that cotton wool until the bite is on, safe and sound, so I just hold on to it. In goes the cotton wool along the line of the arch. I turn my hand sideways so that I can actually see where I'm going inside the mouth. The film goes in flat into the palatal midline and brought up into parallel to the 6. The teeth bite together, and you can see now how the head position lets us see just how parallel that film and tooth are together. I can see through to check that I've got exactly my beam coming where I want it to, and the film should be centred usually on the first molar. Get the height of the palatal midline to position the film parallel, but if we want to go on to the second or the third molar, then the film should be moved back probably once or twice. Don't go straight in for a 7 and an 8, because the patient will panic and they will gag. So we want to start at the 6 and go back slowly to the 7 and slowly to the 8. Each time we go into a position of gag with the patient, they should take a big deep breath in through the mouth, not through the nose, and they actually lift the soft palate high as they take the breath in, and they continue to mouth breathe for the duration of the examination. So in we go, line up, and everything's looking good. Again, if the head's in the wrong position, you can see just how easy it is to get it wrong. We're in a foreshorten mode here, and we want not to be taking our films like that. The film's in the wrong position, it's too close to the tooth, and the spacer cone is in too steep an angulation and is going to foreshorten. If the teeth are not biting on the block, don't press the button. We're going to see through that ring. The teeth aren't in the block, don't press the button. This one here, the tooth and the film have been far too close together, and in fact the upper part of the film has been bent in the roof of the mouth. So remember, we're using a parallel beam, and that's half the story of paralleling technique. The premolar area start at the 6, and then the only thing you do to change is not bring your film forward because you'll hit the hard palate, but center yourself on the 6, and the next movement is bring the rod round. So let's go back to the 6 and forward to the 4-5. Back to the 6, forward to the 4-5. You can check through the ring and see that your beam is going straight through the premolar area. Rotate the rod to position the film without bending in the hard palate, checking that our beam is going where we want it before we line up. Lower positioning, again, we check the buccolingual expansion, stroking the floor of the mouth. Place the film onto the incisal edge and hold firmly. Ask the patient to bite and hold, and as they bite, the floor of the mouth is at its most relaxed. If we're going to change the film from this position, we do it with the mouth open only slightly, so that the floor of the mouth doesn't tense up, and we can move the film back as we go back to the 8s. So, hold back the soft tissues, film goes in flat, into parallel, down, onto the top of the tooth in question, to the plastic hitting hitting the crown of the tooth, and then the cotton wool pops on top, patient bites and are most relaxed. Now that's our position for our 6s, and if we wanted to go further back, the patient would open ever so slightly and we move everything back a bit and stop, and then open slightly, move back and stop, breathing always through the mouth. Ring goes in to skin and line up, giving us nice parallel films, nice bone levels, no overlap on our enamel at all. No, it's not even as far as any overlap on the enamel, never mind as far as the enamel-dentine junction. If we go beyond the enamel-dentine junction on an overlap, it's a repeat film because we can't view it. But see just how clearly these perio films are shown with nice paralleling technique. Nothing is missed out. If we have teeth that are in the middle of, well, we might be in the middle of a surgical, we've got teeth on either side taking the bite, that's fair enough. But if either of these teeth was missing, we would have to put in crowns to make sure that we were lying along the line of the arch to get that film just right. Premolar, same situation. We go in onto the 6 and then we rod turn. So onto the 6 and then rod turn. Onto the 6, rod turn for the premolar. That's all we have to do. Then in pops the cotton wool across, patient bites, nice and relaxed, check through the ring and bring in your spacer cone. And we've got nice spaces here showing in our premolar region, but as we're getting back towards the molar areas, we're starting to go overlap, where our angulation along this line of the arch is different to the angulation on this area here. So here we haven't had any cotton wool put in, and the film is wanting to fall down in this angle into the space. So we've missed these roots and would probably have to go back in to do another film. So the use of cotton wool and lining along the arch is tremendously important if the patient is missing teeth on the arch. Being very aware that our spacer cone, that our ring on our bite block is in the correct position. So always check through with your eye to make sure that you haven't put the circle on upside down, in which case you're going to cone off when you line up. Bite wing positioning is slightly knackier. We have a number of different bite wings, but basically it's the same holder, it just turns over to the right or to the left. We'll see here we've got to be some distance away from the teeth. The biggest mistake with bite wings is we think, well, it's only half a film that's going to be in that part of the mouth and half a film on the lower part, so we can snug up close. I would say it's probably the most uncomfortable when you get closest to the teeth. So remember the parallel beam and let's get a wee bit further away. We must have our ala tragus, our upper occlusal plane, parallel to the floor. This is the only mandatory head position in paralleling technique. I say we should use head positions for all paralleling technique, but by the book, bite wings are the only mandatory one. You've got to be able to envisage the upper teeth and the lower teeth all biting together. So, ala tragus line parallel to the floor, film in the bite wing holder parallel to the dental arch, close to the lingual aspect of the lower teeth. I'll show you in a wee minute what this means. The anterior aspect of the film is 3 mm mesial to the first proximal surface of interest. It gets quite complex when you write it like this, but this is really what we're trying to achieve. X-ray beam centred both horizontally and vertically to the locator ring. So first of all, let's explain what we mean. Let's look at the arch formations first of all. With a U-shaped arch, the one film position will do, it might be 2 films, but the positioning is going to be the same from here to here, allowing the beam to come through the spaces. So let's look at every arch before we go in to do the films. With a V-shaped dentition, we're talking the same again. The film goes from the 4-5 to the 6-7-8 on just a move back, but in fact the beam's coming in exactly the same line. But this is the mouth that we very often have to work in. It's the U-shaped arch, and in fact the angulation for the premolar is totally different to the angulation to the molar. The biggest mistake I see with general practitioners is you position with this position when you're doing the premolar and you end up with huge amounts of overlap. So remember to look at your arch formation before you decide where your film is going to be lying, and that the 4-5 and the 6-7-8 can be quite different. With 2 bite wing holders, the one on the left is the one that we would normally use for caries, and the one on the right gives us superb bone levels. If you don't want apical attachment, the one on the right is lovely for perio. You don't do anteriors, but you would do, to be honest, we don't do anteriors that I've ever come across in Britain. But you might do it in another country. I can't speak for them. But we would do 2 on the verticals and either 1 or 2 depending if we have 8s. If we have 8s, we'd do 2. If we have a full complement including 8s, we'd do 2. And if we don't have 8s, we would do mesial 4 to distal 7 on 1 film, clearing all the spaces on this first film. So, horizontal bite wings. Head position ala tragus. Check our arch formations and get the patient to bite into their natural occlusion. Look at the relationship between the upper teeth and the lower. Is it the upper teeth, the 3-4 space, is it most anterior, or is it the lower 3-4 space that's most anterior when the patient bites? It's usually the lower, which makes it very easy, because what we do then is in goes the film, and it is positioned onto the lower occlusion along the line of the arch, exactly so that we're getting parallel along the line of the arch. We're going to get the front edge of the film just behind the middle of 3 on the lower. That means we're going to pick up maybe about 3 mm onto 3. We're going to pick up mesial 4 to distal 7. As the top teeth come down to bite, we know we're going to pick it up because in fact the lower one was most anterior when we checked the original bite. If the upper is most anterior, we have to displace the film forward, but don't leave your film hovering in mid-air. What I want you to do is sit it onto the occlusion so that we get it along the line of the arch just perfectly. The patient then bites. I would tend to hold the front of the block then, get the patient to open up just a tiny amount. I would just hold up there with my finger and thumb. I'd look through the ring, I'd see the front of the film and go, I need that 3 mm onto the lower 3, and then I'm going to pick up all my spaces if I've got my line correct as we go along. So, patients smiles, patients always smile, and we must be able to see them when we press that button. Nobody closes their lips when they're getting x-rays done, because we don't know if they're keeping the bite on. They've got to keep the bite on. So, smiling, in comes the spacer cone, onto our circle, lining up our notches. Lovely films. Now, here we've got 5 to 8, but we've got 4s there. So in a perfect world, if we had lined up as I had just explained, that film would have been quite a wee bit further forward, and we would have probably got onto distal there, because that 8's not even erupted, but this one is, so it counts. So we might well have had to do a second film for that back 8. Our bite wing films are fantastic using these holders. I really think they're wonderful holders. They give us the best bite wings. I've not found anything else that touches them. We can use them with phosphors, and we can use them with ordinary emulsion films. We can use the vertical bite wings exactly as I said before, but the film is put up and down the way. It looks a bit of a mouthful, but in fact it's not bad at all. Just don't get too close. Again, check your buccolingual expansion, find your softest part and put the film into it. Don't come too close to the teeth. That's the biggest mistake. Patient bites, check through the ring. That in fact is the 4-5 area, and that is the 6-7-8. The 4-5, 6-7-8. Completely different angles. 4-5, 6-7-8. It's on the rod turn, not moving the film, but moving the rod to get it so that the beam is going to go through exactly what you want it to go through, giving us nice horizontal bite wings with lots of information. Endo we can use as well. One little problem I have with endo is lack of back support on here, and what I tend to do to back support my film so that they don't bend is I use the old-fashioned little sticky tabs that we used to use for bite wings for children, the wee cardboard bite tabs, and I close one over so that it's just 2 bits of cardboard stuck together, and I slide it down the back of my film to give it some back support so that it doesn't bend when we're doing our endos. Patients are always going to be biting on the outer aspect, and when you do an endo film, you're in a much better position than I, because you're there before you actually put the files in. I normally come in at the back end of everything when there's rubber dam and files and glasses and bibs. Well, if you're there right at the beginning, take the bite block, turn it round the wrong way and put it into the mouth. Look through this little hole. So we're looking at the teeth through the hole till we find the exact view that you want when you're going to take your resultant x-ray. See where your shoulders are and write it down, millimetre perfect, so that effectively, if we're using rubber dam, we can take the rubber dam frame off, we can let it fall down over the tooth. It's like a little umbrella. But we don't need to see the tooth, because we worked it out before where the shoulders went, and you just slip your film in behind the rubber dam with the teeth in, biting the shoulders on either side exactly as we wrote down before. So upper anterior, we are on the outer aspect of the block. Lower posterior, to be honest, I would go further and take it to the outside aspect of the block. This block is quite short. In a perfect world for the anterior, I'd like that block to be slightly longer to allow us to be more parallel as we were with the blue block. And then we end up with some lovely endo films with all our files showing beautifully. They work very well. They're better than the old grey ones that you used to have with Rin. I don't know whether they still sell them, but I like the green ones. The green ones are solid, and everything in the Rins can be autoclaved. Now what I'm going to look at for 5 minutes is panoramic. I'm just going to slip down onto my panoramic area, so just stick with me a minute. I'll be right there. Here we go. Extraoral technique. I just want to go over panoramic positioning for those of you. What we're looking for, lovely films with everything showing erupted, unerupted and bony detail as well. We want the image of the entire dentition in one film. We use intensification screens, we use light as our image, or digital. We use light to cut our exposure down to our patient, but it sometimes therefore doesn't give us as good a film as we get. Intraoral layer, the intraoral films are the best. We have an image layer or a focal trough, and machines are designed for the average jaw, but correct positioning is absolutely essential. Every panoramic radiograph tells a story. Dental panoramic radiography is a little corridor, a little horseshoe focal trough, as near as the shape of the arch as possible, but we've got to make sure that the patient is troughed correctly, or we're not going to get everything in focus. The X-ray tube is opposite the cassette or the digital detector, and the tomographic movement is produced by the synchronized movement of the tube and the cassette detector in the vertical plane. So it rotates around the head. Most of you know what they look like. The focal trough is determined by the unit using different stationary centres of rotation. Sometimes they're 2, 3, sometimes it's a continual moving centre of rotation using multiple arcs, giving our final elliptical horseshoe, or a combination of 3 stationary centres of rotation and a moving centre of rotation. But what we have is a slit X-ray beam traversing the film detector, exposing different parts of the film as it goes around the head. All the centres of rotation will be in focus, representing the focal plane, or a section that will appear in focus in the resultant tomograph. Most modern equipment has continuous tomographic cycle with rotations adjusting automatically as it goes around the head. In goes the film. Here we have Ian. I didn't mention he's a muscle man as well, so he's really difficult to position. So when we position for panoramics, let's start from the floor right up to the head. So first of all, it's floor, and the first bit we get to is going to be our hands. Chin goes up onto the ledge. We're going to use Frankfurt plane, which is lower border of the orbit to the tragus of the ear, not the upper occlusal, but Frankfurt. So, chin on, head coming slightly forward, but getting our bite block in to get things troughed. Head comes further forward, and we're into Frankfurt plane. Checking our mid-sagittal lights are exactly correct, and our Frankfurt plane lights, making sure everything is lined up correctly. Closing the ear, the head holders, and closing over the cassette, ready to take the film. We do the same before we take the film. The patient puts the tongue to the roof of the mouth and closes their eyes. Tongue to the roof of the mouth to get rid of the black airspace, and closing the eyes because the camera goes around, and as it passes their noses they get kind of interested, and lots of patients go, oh, and they follow it, and we get movement, so that's no good. But we can have digital panoramics as well, with OPTs and cephalometry units stuck onto them as well. Very similar to the old-fashioned ones, with the emulsion ones, but these are digital, with patient positioning the same, holding the handles, getting a mid-sagittal and Frankfurt laser positioning to canine, and we actually use focal trough positioning with canine lights. Patient in the correct position and ready to x-ray. We have software tools for contrast and brightness, for optical image. We have fine adjustment for segmental panoramics. We don't have to take the whole lot if we don't need it. We can cut it down and get lots of information just on the area that we want, cutting our dose down to our patient. Sometimes the patient wants, it is needed that they have a hard copy, and we have dry laser printers which can give them what looks like an ordinary x-ray film. With panoramics, they remove all jewellery, dentures, standing with the spine straight, Frankfurt plane parallel to the floor, mid-sagittal plane vertical, central incisors biting in the groove of the bite block, tongue against the palate. Common faults: too far forward on the block, too far back, chin up, chin down. Mid-sagittal plane not vertical, head rotation, no tongue to the roof, patient movement, patient slumped, spine shadows. Let me show you. Chin up, our occlusion flattens. Chin tucked, we have V-ing and a lot of overlapping. Too far back, our anterior teeth are splayed. They're the wrong shape now, they've got much wider. Again, too far back. Spine shadow because the patient wasn't standing straight. Orthogonal, this is a fantastic way of taking panoramics, because this one has changed the beam to go through the spaces and can now be used for children rather than having to get in to do bite rings on them. So the machines are keeping up to date and doing fantastic jobs. Patient movement. I actually had a patient who walked out halfway through. You can actually see there, but the tongue's up to the roof of the mouth because we've got no big black airspace, and you can see the tongue being pushed up to the roof there. And ghosting of fillings, So can you imagine if that's ghosting of fillings? Can you imagine what it would have been like if we'd had earrings or node studs left in on that patient? Now, at that point, I will say it was a fast hour. We're going to have a wee look at one or two questions, and I'll tell you what they are. What's the difference between an OPG and an OPT? Absolutely nothing. So they're the same, it's just different machines that we've got used to using. I've always used to talk about OPTs, but OPGs are exactly the same. Good tip on endofilms, somebody says, but sometimes the apices are missed with the green holders. With the dam pulled back on the 6s and 7s, I've had to use suture holders. But this is a big hit and miss, as I can't aim the cone without an extra oral guide. I would quite seriously get in there with the holder. First of all, I want you to line the whole thing up and find out exactly where the shoulders are. Millimetre perfect, and write it down so we know where we're going. If these shoulders are in exactly the same position, you'll get the ends of your roots on. Do use as small a clip as possible on the crown area. If you use too large a one, you're going to have difficulty getting in with your endo holder. Somebody's asking if I do a similarly live course in London. Not as far as I know, unless it's somebody it's a look-alike. What about positioning for separating mesial roots of the lower molar? Right, what we want to do here is something called parallax. You do 2 films when you're trying to separate roots, and you have to do them centred on different parts. So say it's the mesial roots of a 6, be it an upper or be it a lower. Very often it's the upper we're trying to stop the palatal root superimposing. So what we want to do is do 2 films. The first film for a mesial root problem would be centred in the 5. So we'd have 4, 5 and 6. And the second film would be 5, 6 and 7. So our centering point on the first was 5 and our centering point on the second was 6. Take an area on both of them for reference. Find out as your eye moves back, pretend your eye is the beam. As your eye moves back, that's the way the tube went, from the 5 to the 7. Move your way back and say, has the root gone with me or has it gone the other way? You'll separate your roots that way, and by using same lingual, opposite buccal, or my palatal goes with me, you'll be able to parallax to be able to find out what's where. Do we have to precaution while taking an X-ray or an OPG for a pregnant patient? Well, the precautions that we use for taking an X-ray or an OPG for a pregnant patient is, do we have to do it? The X-ray beam isn't going to be irradiating the fetus, but from a psychological viewpoint we would be wanting only to be doing these if this is an emergency, because of the historical aspects of patients being very unhappy to have X-rays. So it's when the fetus is irradiated with the primary beam that we have to use lead, and we wouldn't want to be X-raying when they were pregnant. But I would say that it is a recognised fact that we check for, and is recommended that we check for all patients being pregnant. If a patient is having an intraoral film and it's an emergency, we can explain to them that the primary beam is not going anywhere near the baby, but if they want a lead apron, it's not going to do them any harm at all. What we will find though is if they are having a panoramic, no matter what, they must not have a lead apron, because the lead apron goes behind the head, and the panoramic is angled with the beam coming up at 8 degrees behind the back of the head, and it throws the lead across the mandible, so we actually cannot use it. So precautions, yes, this is something as dentists that you have to check how essential is this film, and can it be put off until after the baby is born. In a hospital situation we still have lead aprons around, although since '94 we no longer legally have to use them. There's a question here. I was wondering if there's any way to take good bite wings for crowded dentitions, as I often notice a lot of overlap. Right, the situation there is, take your first film in the line of the arch as you see it. take the first film and then view that film before you go anywhere else. For the crowded area, you may well have to go in and do a different image. But as I was talking about looking at the arch alignment, you have to be really careful in trying to get along the line of the arch. But say we've got a 5 lying out of the arch because of overcrowding. There's a very good chance that that beam is going to clear one side of the overlapped tooth. And until you actually see that film, you're not going to know which one is clear. Once you find out what's been cleared, you can go in and take another film on the other side that's overlapped. Put your fingers on either side of the tooth that overlap so that you can actually feel the exact angle that the beam is going to have to go in to separate them. To get a very obscure angle, use the little tiny vertical bite wing holder. It's for a size nothing film and it's a vertical bite wing, and you can turn it at a very, very wild angle, allowing you to get through a very strong mesiodistal or a very strong distal mesial angulation. And that is what I would tend to use when I am taking bite wings for crowded dentition. I have Joanna Burns saying she's found it very helpful and interesting and a great way for course subjects. Thank you very much, Joanna. I'm absolutely delighted. Penelope, are there RIN holders suitable for digital sensors such as Kodak? Yes, there most certainly are. This is for your direct digital sensors. We have holders which are specific for the directs with the cables, but there's a new holder that's just coming out with Dentsply, which hopefully is going to be in Britain before Christmas, which is a universal holder for the directs. But if you are working with a digital sensor which is a phosphor, then just use the ordinary films. If you're using indirect phosphors, then use the ordinary RINs. If you feel that they slide slightly in the ordinary RINs, please put in, yet again, that little bit of cardboard that we used to use for the bite wings for children. Slide it down behind the film, and that will just make sure that it doesn't move around. In fact, what I do with phosphors is I stick the sticky cardboard bite tab that we used to use for the little ones, and I stick it on either side of the phosphor waterproof cover, which gives me a thickening that's solid on the phosphor, stops it running back and forth in the RIN, in the RIN holder, the bite block, but also allows me to centre straight in onto the centre of the white cardboard, which is a great way to do it. But there's definitely lots of digital sensor holders out there. Have a wee look around, but there's a new universal one from RIN which I have been trying out, and it's working with all the direct ones, and when it comes to the phosphors you don't need to worry about it. Sonal, I am delighted that you have enjoyed the course, and I hope to do some more for you in the future. Can you tell me about more parallax techniques and any pictures? To be honest, I could tell you loads about parallax techniques, but I think we haven't got time to do it tonight. Santosh, my clinical room is too small. Can I stand in the same room during the exposure? Well, normally you would be standing approximately 2 meters away and as far as your curly coil takes you. But if you're out with your 2 meters, have a word with your radiation protection advisor. And if you are beyond the 2 meters with your machines that are kept totally up to date, then you would tend to be quite safe in the same room. But we always get as much distance as possible. If your clinical room is too small, can you move out the door? Use your curly coil. Give yourself some distance. You move out the door. You might not be able to see your patient, but all you need to do is line up a mirror so that it shines on the patient's face, and you can pop your head round the corner. Just get the important bits of you, like your reproductive organs, away as far as possible. You can peek round the door. So distance is our way. Remember the inverse square law. Karen Edmonds, I'm very glad you enjoyed the lecture. Good radiographic tips. What do we do for young children, 5 to 6 years old, intraorals? Are the holders not too big? Not when you cut them down like I did. So cut them down and use them that way. But if you're going to be doing bite wings with little tiny chicks and they can't cope with the small holder, use the cardboard bite tabs. But don't use one. Use about 4 or 6, and thicken it all up and give yourself a long rod with them so that you can put your spacer cone right around the rod, bringing us into the correct focal skin distance and giving us an exact position. If we do another one of these courses, I'll get some pictures and be able to show you exactly what I'm talking about. Now, let's have a wee look. I'm just having a look down through the questions. Which holders would I use with digital sensors? I would use, to be honest, I think a lot of the digital sensors which go with the direct digitals have not autoclaved well. This new holder that's coming out seems to autoclave very well and holds the film very securely, so I think that's a good one. If you give me a second, I'll have a wee look through, so bide with me and I'll have a look and see if I can find where we are, and I'll show you actually what I would be looking for. Just give me a second. So I'm just going to pop through. So lots of digital sensors, phosphors with QA. Here we are. This is the new digital sensor holder that for the direct cables that's coming out from Dentsply and should be coming out on the RINs hopefully before Christmas. I know it's in America, but it's not in Britain yet because I've got lots of people who are very interested. It's one rod with lots of different holders and one ring. So and it's actually very easy. It looks a wee bit complex, but I've worked with it and it works a treat. So we have yellow for the posterior, blue for the anterior, and it's universal, and this part here holds the cable nice and firm. And one's for the bite wings as well, allowing us to do horizontals and verticals for little ones, for the small holders that you get with the direct cables, and also for our endos. Nice, aren't they? I think they're absolutely delightful. They're a bit of a mouthful, but of the holders that I've seen, these are the best ones. Vertical bite wings with size 2 or size nothing. Most definitely size 2 for adults. The only time I would use a size nothing on a vertical bite wing is when I'm trying to get into the crowded mouth and I'm just going through one little space. Let's see. We've done that, I think. Sorry, I missed the anatomical points when you're referring to the mandibular plane. Right, just remember, upper teeth, we're going to do alotragal. Lower teeth, it's corner of the mouth tragal. So it's approximately upper occlusal plane and lower occlusal plane. So soft part in the ala of the nose to the upper part of the external auditory meatus. What exactly is the function of the collimator? Well, we have the spacer cone, which gives us the distance and also picks up on any scattered radiation that's going in the wrong direction. It gives us a distance, and we have a collimator which goes on the end. You saw the fact that I was working with a collimator, with a rectangular collimated spacer cone. The function of the collimator is to cut down on the dose to the patient and still allow us to get the information that we need. We don't need to irradiate an area which is not going to be covered by a film. So to cut our dose to the patient by at least 30% has got to be the way ahead. And so I would say that rectangular collimation should be the norm. Position yourself close to the tooth, look through the ring with your X-ray eye, do everything methodically, and use the collimator and cut our dose to our patient. I'm afraid that's all we've got time for this evening. I have had a ball. I have so enjoyed myself. I do hope you have taken something away from this evening. Take very good care of yourselves and have a lovely weekend. Bye-bye.